Jenny Mancuso. Thank you for joining. I'm a pediatric dermatologist at University of Michigan, and I'm very excited to kick off tonight's virtual journal club, hosted by the Society for Pediatric Dermatology and PEDRA. So we're going to get started tonight with the paper on ritlecitinib and alopecia, and I'll let Dr. Katie Sue, pediatric dermatologist at Dartmouth, take it off. Thank you.
Great. Thanks, Jenny. Well, I'm very excited to welcome our first speakers for this evening, Kim Nguyen and Dr. Maria Hordinsky, who will be presenting their recent publication entitled Efficacy and Safety of Ritlecitinib in Adolescents with Alopecia Areata, Results from the Allegro Phase 2b/3 Randomized Double-Blind Placebo-Controlled Trial from Pediatric Dermatology. Kim is a clinical research fellow in the Department of Dermatology at the University of Minnesota and a medical student at the University of Nebraska Medical Center. And Dr. Hordinsky is professor and chair of the Department of Dermatology at the University of Minnesota and is also the director of the department's clinical research division. And so welcome, Kim and Dr. Hordinsky, and thank you so much for participating in this evening's journal club.
Well, thank you very much for the invitation to join this stellar group. So we can move on to the next slide. Kim is handling the slide, so we'll go to the next slide, which is a repeat of the introduction of this paper. And next slide, please. So Kim is going to go through the background and the methods used in this paper, and then we'll go through the results and conclusions and discussion, and then open up the presentation for Q&A. Kim, take it away.
Dr. Hordinsky. Hi, everybody. We're going to start off with going over the background of alopecia areata, ritlecitinib, and how this affects our pediatric community. So in the United States, an estimated 6.7 million individuals experience the impact of alopecia areata. 31 to 48% of these individuals actually present before the age of 20. So this affects many patients at a very early age. And earlier ages of onset actually portend a worse prognosis. And these are typically the patients who have a more severe and chronic hair loss condition. So a recent survey actually found a lot of psychosocial impacts of alopecia areata too. So 48% of the pediatric alopecia areata patients in this survey felt embarrassed by their hair loss. And a third of these patients also admitted to staying home from school at least once due to alopecia areata. Okay, so next, Dr. Hordinsky will review some background on the JAK inhibitors and medications.
So the JAK family is fascinating, and it's even more fascinating to recognize that the JAKs are only about 30 years old. They were first discovered in a laboratory in Australia. And here we are 3 decades later, and we have 2 approved drugs for alopecia areata. In June of 2022, the FDA approved baricitinib for those 18 years of age and older with 50% or more hair loss. And this past June 2023, FDA approved ritlecitinib for those 12 years and older. Next slide. So baricitinib, which was first approved, is a JAK1, JAK2 inhibitor, and ritlecitinib is a selective JAK3 inhibitor and a TEC kinase inhibitor, tyrosine kinase inhibitor. So they're very, very different. Next slide, please. Methods. Back to you, Kim.
All right, so now we'll dive into the methods of the paper. The aim of this study was to evaluate the efficacy and safety of this drug in alopecia areata patients. Specifically, we were looking at a subgroup of patients between the ages of 12 and 17. So the primary endpoint of the study was the proportion of the ritlecitinib patients with a severity of alopecia tool score or a SALT score of less than 20 versus placebo at week 24. And then the key secondary endpoint was also the proportion of patients with a SALT score, but this time less than 10 versus placebo at week 24. So we use a SALT score for our primary and secondary endpoints for alopecia areata to estimate the total of hair loss in these patients. So this score ranges between 0 to 100, with 100 being complete scalp hair loss. And then it's very common for researchers and clinicians to use a SALT score of greater than 50 to categorize patients with more severe forms of the disease. We can go through a quick example of how to calculate the SALT score to the right. So there are 4 regions where clinicians typically estimate the hair loss. So the left side, right side, top, and the back. So the clinician will usually estimate the percentage of hair loss, and then each region will be multiplied by a different weight depending on the area. So for example, on the left, if the clinician sees a 50% hair loss, it'll be multiplied by 0.18, and then you'll get a region score, and then you'll add up all the region scores to get the total SALT score. So this is a table which nicely showcases the 7 possible groupings in this study. So in the dark blue and light blue up top, these are the groups who received a 200 milligram loading dose every day for 4 weeks. And then these patients continued on either 50 milligrams or 30 milligrams of the drug daily for another 20 weeks. And then at 24 weeks through 48 weeks, these patients will maintain the 50 or 30 that they're on. The pink and green in the middle was very similar to the top 2, except these patients did not get a loading dose. And then the orange group were the patients who took 10 milligrams of the drug throughout the entire 48 weeks. So we added this group primarily to see if there was a dose response effect. And then the last 2 is the placebo group. At 24 weeks, this group actually started 50 milligrams of the drug with or without the loading dose. So this is just the same thing as the other slide, just a more simplified figure for people who are not fans of complicated tables. So moving on to the fun part of the presentation, the results. So our subgroup analysis saw 105 adolescents, slightly more females than males, but the gender ratio was nearly 1-to-1. And then the mean disease duration was 6.5 years. We also wanted to note that this group was primarily Caucasian. So for scalp hair loss, we found very promising results when we reviewed the SALT scores, especially at week 24. So looking at the bar graph at week 24, the patients with either 30 or 50 milligrams at week 24 had a SALT score of less than 20, between 17% of patients to 28% of patients. And then when you look at the placebo groups and even the 10 milligram group, you can see that 0% of these patients had a SALT score of less than 20. And then this was the dose-dependent effect that I initially hinted earlier. So the patients that had the most improvement down here in the pink was actually our 50 milligram group. And then the next 2 were also groups that took the 50 milligrams. And then the middle groups here were the groups with 30 milligrams. And then the group that did the worst was the group with the 10 milligrams. So we did see a pretty good dose-dependent effect with this drug. So eyebrows and eyelashes, this showed a very similar effect to the scalp. So again, with patients with the 30 or 50, they seem to do a lot better compared to the placebos with the gray here. Okay, and then lastly for the results, we saw that the drug had a pretty favorable side effect profile. So most of the adverse effects were mild or moderate. The most common adverse effects seen were headache, acne, and nasopharyngitis. There were 3 adolescents who did have serious adverse effects. So these were appendicitis, suicide ideation, and eczema, but it's really unclear if this was related to the drug. And most importantly, there were no deaths, malignancies, major cardiac events, EEs, or serious infections. And then I'm gonna hand it over to Dr. Hordinsky to conclude.
So on to the next slide. So in conclusion, ritlecitinib in this study demonstrated clinician-reported improvement in hair regrowth, and the drug had an acceptable safety profile through week 48 in adolescents with moderate to severe alopecia areata. Next slide, please. So here are the FDA lab recommendations at baseline. One should be checking a CBC with platelet count, liver enzymes. And on the FDA site, it says to check a CPK level, but we are not doing that on a regular basis. It's also important to check Quant Gold and rule out any underlying TB. And we also here will check for hepatitis. And Kim has also put that statement here on this next slide. So let's go to the next slide. So this drug was approved on a Friday afternoon in June, and on the fourth Monday of every month, we have a pediatric dermatology hair disease clinic. First patient that day was a mom who's in clinical research and her 15-year-old daughter, and they wanted this medication. So we prescribed it, knowing that it would not be on the formulary yet or anything like that. And since that time, we've treated or prescribed the medication probably to almost a dozen, I'm going to guess, patients, all of whom are tolerating it well, and the majority are doing very well on this particular drug. Next slide. And this should be our next to the last slide. So what are the differences between these two JAKs? Well, because ritlecitinib also is a tyrosine kinase inhibitor, in the clinical trials with all the patients, adolescents included, diarrhea can occur in about 10% of patients. Acne is common to both JAKs. You do not really have to think about lipid abnormalities with ritlecitinib in contrast to baricitinib. And headache, upper respiratory infections perhaps are a little bit more common with baricitinib. And next slide, please. So that is our summary of this paper. Thank you very much for your attention, and we will be happy to answer any questions.
Thank you so much, Dr. Hordinsky and Kim, for that wonderful presentation. Just a reminder for participants, you can please enter any questions that you may have in the Q&A. So I guess to sort of get us started with the Q&A, I was wondering if you could walk us through a typical conversation that you might have with a patient and their family about the risks versus benefits of starting ritlecitinib for alopecia areata.
It's an interesting conversation because we have so much more data on baricitinib. Baricitinib has been studied around the world. It's been studied in atopic dermatitis around the world. So there's much more safety data on baricitinib compared to ritlecitinib. So in clinic, it really comes down to which drug are we able to obtain. We do go through the side effects that were listed on that one slide. And we go through that with both patient and family, and we do share the knowledge that there's more experience out there in the world with baricitinib. But at the end of the day, if the patient is 11 years, or excuse me, like say 13 years of age or so, or 14 years of age, then the drug that we're going to get approved for his or her alopecia areata will be Litfulo or ritlecitinib.
Thank you. And in the dozen or so patients that you have on ritlecitinib, how have the side effects reported in the trial compared to what you may be seeing in your experience in clinic?
That's the beauty. That's a great question, because the beauty of a clinical trial is that you see a large number of patients. In clinic, I think we're really surprised as how well our patients are doing. And I think the hardest thing to really understand will be the pediatric patient who has a history of low white counts, fatigue, something's just, they're always tired, but no one has really ever discovered what's wrong with them. And they have total alopecia. The pediatrician is concerned, the immunologist has already seen the patient, but then everybody agrees we can go ahead and give the patient a JAK inhibitor like Litfulo or ritlecitinib. Hair starts to grow back, patient starts to feel better. We're actually seeing in real life more positive overall outcomes. And I think that's something we're all going to have to watch as time passes, whether or not some of these patients who have subtle immune abnormalities actually improve over time, and that the other parts of their health actually get better as well.
Thank you. Dr. Hawryluk says, great talk. Some patients were started on Xeljanz before this approval. What is your experience on switching JAK inhibitors for alopecia areata?
Yeah, we published a paper during the pandemic on the use of Xeljanz in both pediatric and adult patients with alopecia areata. And then when we did have to switch, it's an interesting subject, because Xeljanz is a pan-JAK inhibitor, so you're blocking JAK 1, 2, and 3. So when you're talking about these JAKs to patients who've done really well on Xeljanz, and now you're going to switch them, again, it's going to come down to what will their insurance cover. But sometimes we take the gamble and say, if you were in a pan-JAK, then maybe a JAK 1, JAK 2 inhibitor would be a better one for you if you've done really well. But there are patients who don't do well on a JAK 1, 2 inhibitor, and you switch them over to a JAK 3 tyrosine kinase inhibitor, and they do well. So we have the opportunity now to successfully treat a number of patients. Many of them are going to do really well, some will not, and we have the opportunity now to switch and go back and forth, and patients have to understand the biology of these JAKs as much as we do.
Thank you. And then sort of related question from Dr. Joseph Lamb. Great talk and study. Due to cost and the fact that tofacitinib is generic now, do you ever use tofacitinib for patients who do not get reimbursement with ritlecitinib?
We haven't had to deal with that issue. I think Pfizer, who makes ritlecitinib, has been very supportive of patients, and we've been able to get the medication for most of our patients. So we have not had to do that.
And then Anita Hagstrom asks, is there a time frame after which you would call them a non-responder if they have no response to drug?
We use that magic number of 6 months, and it seems in clinic, whether you're working with baricitinib or even ritlecitinib, there will be those children and adolescents who respond very quickly. Like within the first 3 months, you see them just take off. And then there's another group that's much slower, and that you need to give them that full 6 months. And then there's a very slow group. And that's when people really start thinking about, should they stop and switch to something else? But I think Kim works with me too in the Children's Hair Disease Clinic, and I think you really have to give everybody 6 months. Don't give up at 3 or 4 months. You might have vellus fibers coming in, indeterminate fibers. You might start thinking about low-dose oral minoxidil being added or adding topical minoxidil, but you have to give the patient at least 6 months of treatment.
And then Dr. Jenny Mancuso asks, are people checking CPK?
Fewer and fewer people are checking CPKs. There's a clinical trial that's still going on in adults, sponsored by Sun Pharmaceuticals, and everyone still is checking CPKs, and they do go up. If you exercise, the CPK will go up. If you get your blood drawn after you've done a marathon, you probably will have an elevated CPK. And so people expect to see that. And in the clinical trials, the CPK would have to be really, really, really like in the thousands before someone would get concerned. I think the levels we're seeing when we check will be like in the 300s, 400, 500 range. And I think there's a level of comfort with that kind of level. But at the present time, most people are not checking CPKs. Although, as you saw in that one slide, the FDA suggests that it be checked. And so it is something you could monitor and then make your decision based on the data.
And then quick final question before we hand it off to our next set of speakers. How often do patients on ritlecitinib have to follow up with their physician?
So that is another great question, because we work also with physician assistants in our clinics, and we're getting to a point where treating alopecia areata is easy. And I was telling the residents I was working with a couple of weeks ago that, we may not need a specific pediatric hair disease clinic in the near future, because if a patient's doing well, and you saw what the FDA put out there, it doesn't say check labs in 6 months. It doesn't say check labs in 3 months, like in the clinical trials. So if a patient, we do see our patients at least every 4 to 6 months right now. And we do check a quant gold again, definitely at a year, and we check liver studies and CBC with platelet count. So once your patient is doing well, you have to figure out for yourself what you feel comfortable with. And I still think JAKs are too new to everyone, that I bet most of us would not want to have a large amount of time go by before we see that patient again. We feel comfortable with that 4 to 6 month range right now, but I'm not sure we'd go any further than that at the present time.
Well, thank you so much, Dr. Hordinsky and Kim. Thank you for sharing all of your knowledge and experience. And at this point, I will go ahead and pass it off to Dr. Isabella Plumtree, who is a pediatric dermatology fellow at the University of Massachusetts, and she will be introducing our next speakers and article.
Thank you so much, Katie. So it's my pleasure to introduce Dr. Kelly Barry, who's an intern at Newton Wellesley Hospital here in Massachusetts, and an incoming dermatology resident at MCW in Milwaukee, and Dr. Elena Hawryluk, Associate Professor of Dermatology at Harvard Medical School, Director of Pediatric Dermatology for the Harvard Combined Dermatology Residency Program, and a world leader in pediatric pigmentary lesions and melanoma. They are here today to share their paper, Risk Factors and Outcomes of Melanoma in Children and Adolescents, a retrospective multi-center study. So over to you.
Thanks, Kelly. Do you want to get the slides up on the screen?
Yep.
Thanks so much for highlighting our work today. I'm really excited for this paper to be highlighted here. And I just wanted to say that when you work on a large multi-site study that takes years, there are times that are tedious, and then there are bursts of energy that help move the project forward. And Dr. Kelly Berry literally was the burst of energy that really brought this effort over the finish line. So I'm really grateful to Kelly for making the time to present. She's right off of Night Float. And thanks, Kelly. Take it away.
Thank you both for that introduction. So I'm excited to discuss with you all tonight this multi-center study evaluating risk factors and outcomes of melanoma in children and adolescents. So pediatric melanoma is rare with an incidence of 9 cases per million, and this incidence is even lower in children. We know that pediatric melanoma presents with unique clinical features and exhibits distinct biologic behavior. While I'm sure that we're all familiar with the conventional ABCDE criteria that are used to aid in the detection of adult melanoma, modified criteria have been proposed for pediatric melanoma to better capture their worrisome features, which include a higher suspicion for lesions that are amelanotic, bleeding, present as a bump or a raised or nodular lesion, have color uniformity, are de novo, and can be any diameter. Additionally, prominent melanoma subtypes in pediatric patients that are seen less frequently in adults include spitzoid melanoma and melanoma associated with CMN, or congenital melanocytic nevi. We also know that pediatric melanoma have unique histologic features. They are deeper tumors and tend to be more mitotically active, as well as have higher rates of sentinel lymph node positivity, often resulting in more biopsies than their adult counterparts. More recently, molecular testing has uncovered a distinct genetic profile of pediatric melanoma, whereby BRAF mutations are seen more commonly in conventional melanoma, NRAS variants in melanoma arising in CMN, and kinase fusions in spitzoid melanoma. So with that background in mind, the purpose of our study is to better understand the risk factors for occurrence and negative outcomes in childhood and adolescent melanoma, including risk factors for recurrent disease, new primary skin cancer, and overall survival. So this was a multi-center study, a retrospective multi-center study, which included 11 academic centers that were recruited through PEDRA. This study was conducted with a case control design, and patients aged less than 20 with a biopsy between 1995 and June 2015 were queried. Only patients with the top-line diagnosis of melanoma on their pathology report were included. Childhood cases were given a cutoff of less than 11 years, while adolescent cases included children between 11 and less than 20 years. Controls without a history of skin cancer were selected from patients seen in the dermatology program at Boston Children's Hospital from 2000 to 2015. Clinical history, histopathology, and outcomes were collected. For study purposes, prolonged immunosuppression was defined as therapy with systemic immunosuppressive agents for longer than 6 months. Descriptive analyses were performed to summarize patient demographics, disease status, and proportion of patients with predisposing iatrogenic factors, genetic conditions, and skin lesions. Fisher's exact test was used to identify the association between risk factors and occurrence of melanoma. Overall survival was calculated from initial melanoma diagnosis until death or last contact. Survival curves were generated using Kaplan and Meyer methods with standard error according to Greenwood, and survival curves were compared using a log rank test. And finally, to determine association between melanoma subtype and overall survival, a multivariable Cox proportional hazard regression model was generated for each subtype. So moving on to study results, 317 pediatric melanoma patients diagnosed at 11 academic centers were included. 40% were male and 60% were female. The majority, or 73%, were diagnosed in adolescence and 27% in childhood. Overall, 79% had Fitzpatrick type 1 or 2 skin. However, in childhood cases, 32% were with type 3 or 4 skin. Overall mortality was 7%, with mortality rates being slightly lower, 5 versus 8% for childhood cases compared to adolescent cases. Anatomically, melanomas were located on the limbs in 48% of all cases, torso in 28%, and head and neck in 24%. This bar graph compares childhood versus adolescent cases. Childhood cases were more prevalent on the limbs and head and neck, whereas adolescent cases were more prevalent on the torso. Predisposing genetic conditions were noted in 3% of childhood cases versus 2% of adolescent cases. Of those, xeroderma pigmentosum was the only predisposing condition identified among childhood cases, while there were a few cases of OCA and dysplastic nevus syndrome in adolescents with melanoma. Risk factors evaluated included blistering sunburn history, tanning bed use, family history of melanoma or non-melanoma skin cancer, and history of prior radiation exposure either at the site of the melanoma or at a distant site. Blistering sunburns, history of prior radiation therapy at a remote site, and tanning bed use were the most prevalent exposures among adolescent cases, while history of radiation therapy, again at a remote site, and family history of non-melanoma skin cancer were the most prevalent risk factors identified in childhood cases. As previously discussed, there are unique clinical features that are enriched in pediatric melanoma compared to adult cases. As we see in this cohort, while 50% of cases presented with asymmetry, 60% with border irregularity, and 76% with color variegation, we also do see a greater proportion of childhood cases in particular presenting with color homogeneity, amelanotic lesions, bleeding, and de novo lesions. Lastly, of the childhood cases, 14% were associated with CMN compared to 10% of adolescent cases. CMN size was reported in 13 cases, and surprisingly, 46% of CMN-associated melanomas were associated with small congenital nevi, 23% with medium, and 31% with large or giant. Worth keeping in mind, however, is that the prevalence of small CMN is vastly greater than large or giant CMN. So despite this statistic, the risk for melanoma in a large or giant CMN is still greater than a small one. And in our study, of the 17 cases of CMN-associated melanoma, with smaller accompanying nevi or satellites, all developed within the largest congenital nevus. The most common subtypes were spitzoid, representing 31% of total cases, and superficial spreading, representing 26% of all cases, followed by unclassified, in situ, and nodular. Unsurprisingly, spitzoid tumors encompass the majority of childhood cases, representing 59% of all childhood cases versus 21% of adolescent cases. On the other hand, superficial spreading and unclassified melanoma represented 33% and 23% of adolescent cases, respectively. Acral, lentigo, and ambiguous indeterminate melanoma were rare in this cohort. The median Breslow thickness among all cases was 1.8 millimeters, whereas among childhood cases, it was 2.9 millimeters, and 22% of childhood cases were highly mitotic compared to 9% of adolescent cases. Lymphovascular invasion was also more prevalent among childhood cases. So overall, histopathologic features were more aggressive in childhood than adolescent cases. This table shows the association of risk factors for the occurrence of melanoma compared to matched controls, excluding patients with xeroderma pigmentosum. These findings showed that adolescents diagnosed with melanoma were more likely to have received radiation therapy or have had a family history of melanoma compared to matched controls, whereas no significant risk factors for developing melanoma were identified in the childhood cohort. Of the 84 childhood melanoma cases and 225 adolescent cases with known sentinel lymph node biopsy status, 80% of childhood cases underwent biopsy versus 63% of adolescent cases. And a greater proportion of sentinel lymph node biopsies were positive in childhood cases at 55% versus adolescent cases at 42%. Major outcome measures that were evaluated included metastasis, recurrence, and death. 41% of patients had metastatic disease, of which metastases tended to be regional or distant more commonly than local. Overall, 7% of patients died from their disease, and a majority of these deaths occurred in adolescent patients. And in the event that any of you are interested, more specifically in these fatal cases, there is actually a separate paper that combines fatal cases from our institution with other sites that's available for your review. Risk factors, including age, Fitzpatrick skin type, melanoma subtype, and sentinel lymph node status were further analyzed for potential associations with recurrent disease, sentinel lymph node positivity, and metastasis. As you can see from the highlighted column, there were no significant risk factors identified for sentinel lymph node positivity. However, Patients with in situ melanoma had a greater frequency of disease recurrence and a lower frequency of metastasis compared to patients without in situ melanoma. And sentinel lymph node positivity was associated with an increased risk for metastasis at 77% compared to sentinel lymph node negative cases at 23%. Additionally, while not shown in this table, there was also a significant difference in 5-year overall survival for sentinel lymph node positive cases versus negative cases at 88% versus 97% respectively. When further assessing the association between overall survival and melanoma risk factors, no statistically significant association was identified, meaning that the risk factors listed on this page, blistering sunburns, tanning bed use, family history, etc., were all not associated with 5-year overall survival rates. However, there were notable differences in mortality between melanoma subtypes. Among all histopathologic subtypes, the highest 5-year overall survival was observed among in situ melanoma at 100%, spitzoid at 99%, and superficial spreading at 95%. Ambiguous or indeterminate cases had the lowest 5-year overall survival at 75%, followed by unclassified at 78% and nodular at 83%. In fact, compared to patients with spitzoid melanoma, the risk of death was 14.3 times greater in patients with unclassified melanoma and about 20 times greater in patients with nodular melanoma, highlighting critical distinctions between subtypes with prognostic implications. So to summarize, while this study in many ways confirms much of what we already know about pediatric melanoma, for instance, that survival rates are overall quite high, specifically for spitzoid and superficial spreading subtypes, and that these tumors behave distinctly from adult disease, including having greater sentinel lymph node positivity, greater Breslow depth, and higher mitotic activity, there were some surprising findings. For instance, while the majority of patients were Caucasian or Fitzpatrick skin type 1 or 2, approximately 1 in 7 patients were non-white. And of childhood cases in particular, 32% developed in skin types 3 or 4, highlighting that childhood disease specifically can involve more diverse skin types. Additionally, contrary to expectations, 46% of CMN-associated melanoma arose within small CMN versus 31% in large or giant. While these findings were also observed in a 2021 study published in Dermatology, it's important to consider that the prevalence of small CMN is vastly greater than large or giant, so the risk of developing melanoma is still greater in larger congenital nevi. Importantly, our study also supports that risk factors associated with developing melanoma are different in children and adults. The risk factors commonly associated with adult disease, such as tanning bed use, blistering sunburns, and immunosuppression, were not statistically significant in our study. Risk factors were also assessed for their prognostic value for determining negative outcomes such as metastasis, the development of subsequent skin cancers, and death. Of the risk factors evaluated, only treatment with radiation therapy was associated with the development of subsequent skin cancer. Overall survival rates also varied significantly by melanoma subtype. Supporting findings from a 2021 retrospective study published in JAAD, spitzoid melanoma demonstrated an excellent prognosis with a 99% 5-year overall survival rate, which is significantly higher than nodular or unclassified subtypes. And patients with nodular melanoma had about a 20 times greater risk of death than patients diagnosed with spitzoid subtypes. This variation in outcomes between melanoma subtypes underscores the importance of distinguishing pediatric melanoma variants to prognosticate and counsel patients and families appropriately. And it is also potentially valuable in informing management, in particular, determining the need for a sentinel lymph node biopsy, which can be controversial in pediatric melanoma. While prior studies have yielded mixed results, our study did show a significant difference in 5-year overall survival between cases with positive versus negative sentinel lymph node biopsy, and also demonstrated an increased risk for metastasis in cases with sentinel lymph node positivity, supporting that sentinel lymph node biopsy may be informative in prognostication. And finally, before concluding, it's worth noting that one of the major strengths of this study is that we were able to robustly look at risk factors for melanomas across a large cohort of pediatric dermatology patients, while a big limitation is that the cases were recruited from a time period that predated modern treatment strategies such as targeted therapies and immunotherapy, which were not approved at the time of the study. So with that, thank you all for tuning in.
Thank you so much, Kelly and Elena. That was a wonderful presentation. We have just 1 or 2 minutes for questions, so I'll get us started. I appreciate that was a surprising result in some ways for the number of small CMNs that were involved with melanoma, but I appreciate how you put that into context. What do you think we should do with patients in clinic? How do you think we should counsel about that risk to families with a child with 1 or 2 small CMN?
So we see small congenital nevi every day in the clinic. And I think a lot of patients come in asking about them, and some patients come in incidentally carrying them along. If it's a concern, I do like to talk about patients with congenital nevi of any size having a slightly larger lifetime risk of melanoma, not necessarily tied to the lesion itself. So that's why we look all over on the skin. And that most of that's very slight increase in risk for the small and medium congenital nevi actually occur after puberty. So it's not something that we're watching intensely at the site of the nevus every year during childhood, but really educating patients that we want them to take care of the skin, protect from sunburns, monitor the lesion over time, and what to look for that should prompt them to contact us.
Wonderful. And just one more quick one. How about, so in terms of the genetic risk of these patients, I appreciate you had some with XP, and that should be obvious if a child's presenting with melanoma, you'd know about the XP, and one with dysplastic nevus syndrome. How about when you diagnose a patient with melanoma who's a child, would you send them to genetics, or what would your threshold be for that?
That's a great question. And actually, it's important to ask a patient who's diagnosed with melanoma if there's any family history, because a lot of times you can, in that circumstance, identify someone who has multiple family members with melanoma or pancreatic cancer in the family that would put their entire family at slightly higher risk and really impact their whole family's care. And another scenario that comes up are patients with congenital nevi who develop melanoma, who may actually have a germline mutation or other risk, particularly if they have family members with cancer. So it is an interesting finding. Obviously, in this study, a family history of melanoma didn't turn out to be a predictive factor, but it certainly is a well-regarded one in the general melanoma community. And so it may take longer for that genetic influence of having a family history to manifest itself in risk for family members. Same with suntans and sunburns. So even though tanning didn't present itself as a driver for melanoma in the pediatric cohort, we all know that that is a big risk factor for melanoma over a lifetime. So it's most likely that we're looking at a very early point in the patient's life.
Absolutely. Well, thank you so much for sharing your findings with us tonight. I'll hand back over for Jenny for our last article.
Thank you so much. All right, it is my pleasure to introduce Dr. Andrea Zanglin, pediatric dermatologist at Penn State University, and Dr. Pei Kamrani, dermatology resident at Penn State University. They are here today to share their paper, Petroleum Jelly, a comprehensive review of its history, uses, and safety, that was published in the JAD last year. Thank you.
Thank you all. So this comprehensive review article resulted from a series of controversial hospital policies around petroleum jelly's flammability and common myths like comedogenicidity. So Dr. Pei Kamrani and I were discussing this in our Peds Derm clinic, and we realized we were not really taught much about petroleum jelly, even though it's one of the most common, if not the most common skin care product that we use and recommend. Dr. Kamrani, being not only a very kind, but an also very curious resident, eagerly took on this project so we could actually learn the facts behind petroleum jelly. So with that in mind, Dr. Kamrani will summarize all that we learned about the very versatile and decidedly humble petroleum jelly.
Awesome. Thanks, Dr. Zanglin. So we'll be presenting on our clinical review that was just recently published in the JAD. So this is our overview. We'll go through some history, and then I'll go through some of its physical properties, and we'll debunk some common myths. So first we'll go through the history. So it all started with this guy in the top left. So this is Robert Chesbrough. He was a chemist and he would work on petroleum oil wells in Tutsville, Pennsylvania. And during his breaks, he would walk around, talk to the workers there, and would notice when he would shake their hands were so soft, especially for people that were working outside all day. And these workers would say that they would apply something called rod wax, which was this product that would come up with the oil, and they would put it on their hands, and they would even put it on their cuts and open wounds after an injury, and it would help their trauma heal up faster. So he thought this would be a great thing for the rest of the world. It took him nearly a decade to perfect the refining process, but once he did, he patented it and he called it Vaseline. So he got the name from the German word water for Wasser, and then the Greek word oil for Elen. So that's where the name comes from. Okay, so the first the first property we wanted to look at was the comatogenicity. So it's a common myth that it's comedogenic because it's their physical properties. It feels oily, it feels thick, so patients always think it's going to clog their pores. And actually, the first study that looked at this did show that it was mildly comedogenic when you used it under occlusion for 6 weeks once a day. But then the same authors did a similar study, and they actually found that it was not comedogenic, but it also improved acne. And then there was a large human study, so 910 post-adolescent adults, where those patients that used 100% white petrolatum products had a decreased number of their acne lesions compared to those that did not. There's also been some animal studies looking through rat ear, which is a surrogate for human skin. And they also studied that once daily for 2 weeks showed no clinical and also histological evidence of comedogenicity. So you can tell your acne patients that petrolatum will not worsen their acne. And so far with the evidence that we have, it might even have the potential to help it. This really came up a lot in our clinic because of the newest trend slugging. So if you're not familiar with this is when people apply Vaseline all over their face before they go to bed. They look like a slug. And I had a lot of patients come ask me if this is going to worsen their acne. Is this safe to do? And fortunately, from these studies, we were able to let them know that it should not worsen their acne. Okay, and then lots of peds derm in this group. So another thing that we wanted to look through was the safety of petrolatum's use in newborns, specifically low birth preterm neonates, because this is a very special population. They have a very immature epidermal barrier, so we want to be really careful on what we're putting on their skin. There have been so many studies showing that there's a lot of benefits to using it. So decreased transepidermal water loss, decreased severity of dermatitis, improving as fluid requirement, urine output, and electrolyte balance. However, with that, there have been other subsequent studies that have raised some concern about the risk of infection with these premature newborn babies. So there are 2 studies we wanted to highlight. So the first study was a single center. It was a case control retrospective study, had 40 extremely low birth neonates, and they started to incorporate petrolatum into their just standard skincare routine. And they found when they did this, there was a 3-fold increase in the systemic candidiasis. So it went from about 6% to about 18% following this incorporation of petrolatum. They matched the case controls for birth weight, gestational age, how long they needed steroids, antibiotics, insulin, TPN, and the only thing they could find was the petrolatum use. So once they discontinued petrolatum, they found that their incidence of systemic candidiasis actually went back to the normal baseline. And then there was a second, much larger, it was a multi-center prospective randomized study of about 1,200 premature neonates. And they had a theory that prophylactic petrolatum twice a day for the first 14 days of life could reduce the incidence of neonatal sepsis. Now, they didn't find any difference in death or sepsis, but they did find there was an increased risk of Staph aureus infections. They also did find a slight increased risk of candidiasis, but this was not statistically significant. It was about 20% compared to placebo was about 18%. But because of these two studies, a lot of hospitals actually discouraged the use of petrolatum emollients in these neonates because of the concern for infections. However, our recommendation would be babies that have a colloidal membrane or some sort of disorder of cornification, using sterile petrolatum with strict hand washing and infection control, we would still recommend it just because it can really prevent transepidermal water loss and help improve skin barrier. So the biggest misconception, this was actually the inspiration for our review from a consult that we had inpatient, was that petroleum jelly is a flammable, self-igniting topical agent. We actually found that this myth has been traced back for decades from when manufacturers first created oxygen equipment. They put in their documents that oil-based products should not be used around the oxygen. And that vague wording led people to believe, well, petrolatum's made from oil, petroleum, so it must be flammable and we shouldn't use it around oxygen. But actually, the largest manufacturer has studied this. They put it very clearly on their website. This is not a flammable product. Has potential to be flammable if it's over 400 degrees Celsius, but this is not ever going to happen in clinic. And it's not, even if you leave the petrolatum in your car on a really hot day, it's not going to get that hot. The Fire Protection Association, the Safe to Data sheet, also have looked at this, and they listed it as a flammability score of 0, if not very mild as well. And then there's a lot of literature in the nursing literature, and there's videos online, and I also tried it myself. If you just set it on fire, it doesn't melt, it doesn't ignite on its own. So even though it's not a flammable self-igniting product, it can be a fire accelerant if it's impregnated in fabric or in gauze, and it can also lead to a faster ignition time. So there have been several reports. This is an example of something put in the Mohs literature of patients that underwent Mohs surgery. They had Xeroform, which is a petrolatum impregnated gauze on their face, and they lit a cigarette and it caught on fire. So you want to really make sure you warn your patients that even though petrolatum itself is not flammable, there is a higher risk of it catching on fire faster if it's impregnated in fabric, or if it's in hair product, or if it's on gauze. The use of petrolatum for patients on supplemental oxygen is also very controversial. There's not really much data on it. All the oxygen suppliers recommend do not using it, but all their recommendations are just theoretical and have not really been studied. We do not recommend patients that are in hyperbaric oxygen having petrolatum, because there has been studies showing that it can increase the heat of combustion compared to other emollients that did not have petrolatum. So there might be a higher risk of burning as well. So for wound care patients that have Xeroform or some sort of petrolatum impregnated gauze, especially those on supplemental oxygen, you really want to counsel them not to be around an open flame, just because of the risk of burns. So next we'll move on to, can you be allergic to petrolatum? I thought the answer was no, but actually it's very, very low risk. You can be. We love petrolatum because it's non-irritating. We use it for patch testing. But there have been some reports in the literature of people being allergic to the polycyclic aromatic hydrocarbons, PAH for short. That is basically a byproduct of the refining process. It's in a very, very low concentration. There's been one study looking at this. It was a 12-year retrospective study. It was 80,000 patients that are being tested for some sort of allergen, and there was a positivity rate of petrolatum of 0.03. So 3 out of 100 people in that study. But we think the general population would be much lower. These are people that had some sort of presumed allergic contact dermatitis, but studying in the general population has not been done yet. This can be a little bit complicated if you have a patient that is allergic to some sort of allergen and you want to do patch testing, because what's going to happen is they're going to be positive to almost everything that petrolatum is used as its vehicle, and it can present as, this is one of the papers where they present as what they called an angry back phenomenon. They had this hyperreactivity, positivity to all the allergens. So last but not least, so PAH gets a lot of media attention because in oral consumption, it has been implicated in different types of solid organ cancers. So it's a byproduct of the petroleum refinement, but its concentration in petrolatum is very, very low. So the FDA doesn't regulate this. The European Union does, but the studies that have been done on this, it's shown a concentration of about 0.00, like 601%, which is a very low concentration. And petrolatum's been used for almost 150 years. There's been no concerns, red flags, or safety signals that have come out yet about concerns of cancers. And then I also wanted to put yellow and white petrolatum because I thought this was interesting that I didn't know before the study. So they're both the same thing, except white petrolatum has just been through more of a refinement process. So it's more pure compared to the yellow petrolatum. So if you have patients that are worried about this, white petrolatum has less pH and less of everything compared to yellow petrolatum. Okay, so this is our conclusion. So we did an evidence-based review looking at petrolatum's different characteristics. It's not flammable, but it can be accelerant, especially around an open flame when impregnated in fabrics and in gauze. It is non-comedogenic. It has very, very allergenicity properties secondary to PAH. And there's a lot of benefits with using it in neonates, but you really want to use it in caution just because of the studies that have shown that there is an increased risk of infection. And thank you so much. Dr. Nguyen and I love petrolatum. This has been a really big project for us over the past 2 years, and we will take any questions.
Thank you so much. That was a great presentation on one of my all-time favorite products. I really appreciate that. We had a question from the group. Kimberly Morell asked, do you know if the neonatal petrolatum studies were done with single-use packs, tubes, or multi-use jars?
I don't think, hi Kim. Yeah, I don't think that the studies, they didn't clarify how they were using them. Dr. Kamrani can confirm that, but I know it's come up with our infectious disease people because we were trying to do wet wraps on a kid once, and he was trying to convince me I had to use like the little single-use tubes, and I was like, I'll go through that 1 pound jar in a day, don't you worry. So
yeah, that's a great question. So I read the studies before this, and they did not specify. They just say use of 100% petrolatum ointment was prescribed per protocol. Whatever that means.
Okay. Yeah. All right.
But it does raise the question of, like dipping over and over again. We did learn in our study that petroleum jelly it's very hard to grow things in petroleum jelly. So because it's anhydrous and that lacks oxygen and water, so it's very hard to grow anything in it. So
interesting. Very cool. I have to admit, I still feel weird about using Vaseline on acne prone skin. Are you having patients use it like as a moisturizer when they're on isotretinoin, or what do you think?
So far, the evidence hasn't shown that it's going to worsen the acne. So
okay.
I think it's hard to get a teenager to use something kind of greasy, but for those that do want to use it, I just had a kid today in telehealth who said every night he covers up with Vaseline and his acne is responding fine. So.
Wonderful. What are your thoughts about using petrolatum in the nares as we're speaking about isotretinoin? There's like some risk of inhalation.
Yeah. So I again, especially in my isotretinoin patients, I usually recommend using saline spray and a little petroleum jelly up your nose. I don't recommend snorting large amounts of it for that very reason, because it can cause that where you get, I can't remember the name of it, where you get the deposits in the lungs of the petroleum jelly, but that's a lot of petroleum jelly. So I don't think most people would do that. But with regular use anyway.
Great. Okay. Thanks. And I guess how do you respond to parents when they say, I want something natural? Vaseline is not natural. Like, what's your response generally?
What do we say, Pei, usually?
Usually I say, well, poison ivy is natural.
And I say, technically it is natural. It comes from the ground, right? So yeah.
Okay.
One thing that we weren't allowed to put in the study, but to me just shows like how innocuous petroleum jelly really is that the environmental working group actually gives it a pretty high rating, and they don't give it, and they don't like anything that's not supernatural. So
that's probably a very effective response. Yeah, that's smart.
Exactly. So I'll use that as my response, I think.
Okay. Oh, that's wonderful. Well, thank you so much. This was a wonderful evening. I don't think there's any other questions in the Q&A, but I really want to thank all of our fabulous speakers today for sharing their research with us, our moderators for picking the articles, the SPD and PDRA for hosting, and our audience for attending and asking thoughtful questions. These journal clubs happen quarterly, and so we hope that you can join us again in the future. Thank you, everyone. Have a great night.